organizations can succeed in this context. Her research primarily addresses questions of organizational and institutional change in the public sector, and currently she works on her work centers on digitalization in government and administration. How is the governance of public service delivery changed by the introduction of portals and platforms? What influence does digitalization have on leadership and working conditions in public administration? And how can innovation in the public sector succeed in general? So I now pass the place to Professor Tanja Klenk. Professor Tanja Klenk, thank you for you being here. And please.
Yeah, thank you for this kind invitation and thank you for this short introduction. I suggested I try to share my screen because I have prepared some slides and then I can start the lecture. So give me a second to share my screen and bring it into the presentation mode quickly. So where is it? It should be here. Okay. So can everybody see my screen?
Yes.
Yes. Perfect. Okay. So thanks again for this invitation and thanks for the opportunity to present a paper or presentation on the topic of resilience in the case of public health in Germany. So this might be a specific case, but my aim is to introduce you to the topic of resilience and also a little bit on public health and digitalization, and to understand how organizations change in light of a crisis and what resilience in the process of this modernization process can mean. So the project or the lecture I have prepared for today consists of the following parts. First, I want to explain a little bit what is actually my research motivation. And then we delve a little bit into the literature on resilience and seek to understand how can we operationalize resilience, what are actually the analytical dimensions, what can we see if we have empirical data, and try to link it to the analytical concept of resilience. As I said already, I will apply the case to public health in Germany and explain also a little bit how we have collected data, how we have interpreted them, and what are actually our findings and what can we conclude from this, this case. The paper or the presentation is based on a paper, and I'm very glad to have another number of colleagues who co-work with me and who have also contributed to this paper and the presentation. The project we work in is a third-party funded project, and it's funded by the so-called Hans Böckler Foundation. This is a German foundation which is very much interested in decent work in public services and good governance in local public services. And so we have applied there to have a case study on the public health service as an employer. So why this paper or this research on resilience in public health? Probably you can all imagine, so this is in the year 25 and we still have COVID-19 in our mind. And also this project was very much motivated by seeking to understand how public organizations can rebuild after having mastered a crisis, and to understand what they have learned from this crisis and how they develop in the aftermath of a crisis. What we see in Germany and in Europe, and probably also in Brazil, is that resilience have become a buzzword. Yeah, so you use it for all kind of topics. It has been a become a buzzword in public administration, but also beyond in everyday talk. And it's also no wonder, or not surprising, because we have this situation of polycrises where after COVID comes the next crisis, in our case, Ukraine and Israel and all of other things. So the need or the wish to understand how we become resilient is really strong. But in the same time, there are also many research gaps, because while we talk about resilience, we still don't really know how resilience is cultivated or constrained in practices within everyday organizational settings. Yeah, so this is a little bit a research question we try to delve in this paper. And we take one case, but it's a critical case. It's the German Public Health Service, which has a very broad mandate in the German context, which is based on the local level of our public administration system. But that has, even though this has this broad mandate, a long story of neglect. So in terms of resources and in terms of public attention, there was nothing before COVID-19 hit our country. But before going to the empirical findings and the context of the case, let's start with some warm-up questions. So I'm not sure if this is common or not, just give me a sign. But if you are used to talk in this lecture also, I would be glad just to know where you are in terms of knowledge. So I don't expect anything. But if you have any ideas about resilience, ideas or concepts that you do associate with the term resilience, just give me a sign, and you can.
Professor Tanja, you are muted. Yeah.
Okay, sorry. I hope you got most of my speech and I wasn't muted the whole time.
No, it's just on this slide.
Okay.
Okay.
Mhm. So I'm okay. Probably I assume that at the moment you don't know that much about resilience, or are a little bit hesitating to come up with a first idea or association. So, but again, if anybody wants to say just one word on resilience, you can come for. So if not, then I continue. Okay. Perhaps it's too challenging with interaction in this setting. So, okay, let's start from scratch. So where does this term come from? I bring you back in the 1970s. This was already the time where we started to think about resilience. And one of the many origins or roots of these terms go not into public administration literature, but go back to the biological literature, ecologist literature. And one author is Holling, who has come up with the idea of system thinking. So he has challenged the idea that systems always strive for a stable equilibrium. Yeah, he, instead of having this idea of stability, he has introduced the idea that systems are complex. They are complex because they consist of different sub-elements. And what makes a system specific is the interconnection between the different elements. Yeah? And these elements in these complex systems, they are, as said, not stable, but they change, they adapt, yeah, they move around and develop. However, what remains the same are the interconnections between the elements. And this is why the system can keep its identity. Yeah, it resembles itself because the relationship between the elements remains itself. So a system, as Holling said, is an interconnected set of elements that is coherently organized. And resilience then means the persistence of relationship within the system. So the two elements which are really important to understand when we talk about resilience is that there needs to be the ability to retain a certain function, whatever this function might be. Yeah. In case of the healthcare system, it means to heal people and to provide public services to vulnerable groups. So this function needs to be upheld, also in the light of a crisis and also in the light of change. And also the identity. Yeah, so the organization should resemble itself, even though there might be changes necessary in light of a changing environment. So this way of thinking, back to the 1970s, it has challenged the, let's say, the traditional way in science thinking. So what we call the Newtonian normal science, yeah, which was very much focused on understanding equilibriums and driven by the idea that all systems strive to a specific goal, to an equilibrium, and who has a very isolated focus on a specific element of a system, but not this broad focus on complexity. So Holling and also authors who joined this way of thinking, they criticized the traditional science literature for analytical reductionism, yeah, focusing on a minor part of empirical reality does not help to understand empirical reality. Yeah, this is what the big message is of this way of thinking of resilience. So this were the 1970s, and now we make a big step forward and land in the 2020s this time. And this is a book by Romano Pinheiro, who also was perhaps will be present in one of these lectures at some point. He is also very much into the resilience literature and resilience research, and has, together with a colleague, Laura Fregato from Italy, published this edited volume. And from this volume, we take our analytical framework. And this framework, it builds directly on the systems thinking, on the thinking of complex systems, but also moves beyond and brings in some more further ideas, some new ideas. So here with Laura Fregato and Romano Pinheiro, we have elements that resilience is characterized by the balance between stability and change. Yeah, like in Holling's work, we have this idea there must be change. Yeah, a resilient system cannot be the same because crisis always requires adaptation. Yeah. If a system just survives without adapting in the light of a crisis, this does not mean resilience. In the same time, however, radical change is also not resilience, yeah? Because neither the essence, this means the identity of the system, nor the function are retained. Second dimension is the balance between adversity and novelty. So if we go with Ricardo and Pinheiro, we can differentiate between different type of resilience or intensity of resilience. Yeah, there might be a rather low type of resilience which just absorbs. Yeah, if there's change in the environment and the system absorbs this change, but does very little shifts within the system and remains more or less the same. A little bit more medium type of resilience would be if the system is adaptive, yeah? And even more is if we could observe a transformative change, and resilience is then considered to be rather high. Laura Frigato and Romolo Pinero, they have also the idea of temporality. So you cannot just focus on one point in time if you want to understand resilience and the process of resilience. Here you have several points in time where you can observe the time before a crisis, ex ante position, then the period within a crisis. Yeah, what mechanisms does the system have to respond and to cope with crises? And then you have the point in time of outcomes after a crisis. Yeah, what has happened with the system? And finally, you can also think of resilience on different scales, yeah, or different dimensions. You can think of individual, in our case, for instance, the staff or the leaders of a public healthcare system. You can think of organizations, or you can think of the whole system, which might be a state, a nation, or a policy field. So the bigger thing, the bigger environment this organization is embedded in. In the paper, in the research, in the whole project, we focus on the different dimensions, but this paper, which I will present now, focus on the questions, what intensity of resilience can we observe? Is it absorptive, adaptive, or transformative? And we have a little bit further developed and tried to flesh out what does this actually mean? Yeah, if you talk about absorptive resilience. So if we use this term, then we mean that the system that is hit by a crisis just bounces back. Yeah, there's the crisis, and the system, the organization, the public health authority just bounces back and try to be stable. Yeah, and as we have learned with Hollingworth and also Frigato and Pinero, if just bouncing back without learning, without adapting, if just absorptive movements or behavior can be observed, this means a rather low type of resilience. Resilience is more, yeah, or more visible if we see learning while core functions are maintained. And a high degree of resilience can be seen when a system transforms itself, it really adapts to a changed environment, when institutions are reconfigured, when new roles are introduced, etc. Yeah? These are not black-white cases. This is not discrete measurements. Yeah, we need to think of continuums. And it could also be the case that an organization, for instance, goes very far forward moving in terms of resilience in one dimension, for instance, in digitalizing the system, but lags behind in other parts of an organization. For instance, when we think of leadership roles or qualification of staff and learning at a staffing level. So keep this figure in mind. I will come to it back to it later. Now let's have a look on public healthcare in Germany, and I go directly to the next slide because this was, again, I wanted to ask you. So public health in Germany. So if we use the vision of this part of the healthcare system in Germany, we can say this is a quote from a sort of mission statement. We can say that this part of our health system has the responsibility for the health of the population. Yeah, it's not health to the individual citizen. This is different than we talk about hospitals and ambulance care. But here we talk about health to the whole population, which is an integral part or integral component of the modern welfare state, because it's really close to the citizens, and we have it integrated in our local government structures, in our municipal structures. If we think of the healthcare system as a whole, we call it the third pillar, yeah? And it's the last pillar, actually. The first one is the outpatient care, then we do have the hospital sector, and then as a third pillar, we have this public health, population-centered system, which is based in our local public administration systems. We are not that big, Brazil, but we do have quite a number of authorities, slightly over 400, and if you count them very strictly on the local level, then there are around about 380 public health authorities, and we have all of them, or nearly all of them, in our study. As I said already, they have a rather broad range of tasks. So it's the classical thing on infection control and hygiene control, but there are also newer tasks in terms of prevention, counseling, health promotion, when it comes to heat waves, heavy rain, and how to live, how to rebuild healthy cities, and all these newer ideas of health in all policies. While the tasks are rather broad and go also into classical topics of public administration, how to organize schools, how to organize city planning, we see that the understanding of leadership still comes very much from the medical profession, and it's, I think, still equated with medical expertise, which is required to be the leader of a public health authority, which is not wrong, actually, but perhaps might not be enough to have a modern leadership idea of a public health service authority with a rather broad mandate. So, as said, even though we have, I'm now in the last point here on this slide, even though there is this really broad and legally fixed mandate with wide-ranging responsibility, the system, this third pillar as such, has long lacked visibility, resources, and also strategic integration into other parts of the health system and also other parts of the public administration system. This all changed in light of the COVID-19 pandemic, when most of us realized, probably the first time, that there is such a system like a public health system, because usually in everyday life as an individual, you don't get in touch with the system, with this public health system. You are more in touch with hospitals or ambulance care. So in light of the 2020 events with the pandemic, shortly, I think it was already this year, in the first year of the pandemic, the government at that time decided to change the poor situation and stop the neglect of the system, invest and to invest a considerable huge sum, at least compared to our standard investments in the system, immediately. Yeah, so 400 billion euro. It was a huge package. It was just thrown over the system, yeah, in order to strengthen the system. Whatever this could mean in light of a crisis, yeah. And we observe, so in a point 5 years after this huge stimulus package, how has the system actually changed? And how can we describe this change, yeah, in terms of our resilience perspective? So has there been some learning? Has there been some transformation? has there been only adaptation, so that the minor intensity of resilience, where you just bounce back without learning from this crisis. And learning, we would understand not to have a narrow focus anymore on hygiene and infection control, but also to move forward, to go into health in all policies, to understand that pandemic prevention requires that you have to build healthy cities, to introduce preventive measures before the next crisis comes. Our empirical basis is free. We went in 3 steps. We went through 3 steps to collect data. We started with a policy document analysis, and then from the results of the policy document analysis, we have designed an expert interview questionnaire and conducted a number of expert interviews. This was now a year ago, with ministerial officials, with members from boards of the public health system, federal associations, staff council representatives, etc. So we tried to make sure that we have really a mix of perspective on the system, and not only talk with really experts, but also with people who look from outside on the system. Again, the results of the expert interviews we used to design an online questionnaire, which we have implemented in spring this year. And the target group was all public health authorities we do have, so around about 380s. And we asked them on a very long questionnaire. So how have you changed? How has the institution changed in the past 5 years, and what expectations do you have regarding the functions and the development of the public health sector at the local level? We have reached out to all health authorities. Around a third have answered, which we think is which we think is not too bad. Which we think is not too bad. To have not a representative, but a satisfying picture from the empirical point of view. Okay, so but before coming to the findings, let me explain you how we have in our questionnaire actually operationalized resilience. So because this is still a broad term, even though I have already explained, we need to think in processes. We need to think in types of resilience, in considering the degree of change, and so forth. You still need to break the concept down to smaller parts of questions, which the respondees and the interviewees can digest and can come up with an answer. And in this particular paper now, we have included 3 questions, which we think give a sign and also an understanding how people and leaders in light or in the aftermath of a crisis try or try not to develop their organization. First of all, we tried to understand what are actually these leaders, and what is leadership capacity, what are the qualifications of those leading or being on top of these organizations, what is the leadership style, do they seek and have the ability to organize workflows and to professionalize them? Can they motivate staff? Do they think strategically when developing their staff? What do they train them for? And all these things related to leadership. The second thing we think is really significant for resilience and a sign for how people strive to strengthen resilience or not is the resource capacity. Yeah. So what are my personal and technological resources? What qualifications does the staff have? What are the task profiles? And also, if you think of infrastructure, what is the degree of digitalization? Yeah, is this becoming a modern authority, or is still very much done with paperwork and time-consuming procedures? And the third dimension is what we call strategic development capacity. And this is the idea that the public health authority operates in a network, or in a possible network of other authorities and of other associations and civil society organizations. And do these leaders of public health authorities think of nurturing this network, building the network, and adding or organizing additional resources through network building and network development. So, building capacity through external coordination. So now I come to my findings. I start with leadership capacity. First, one quote from the expert interviews, which is, I think, quite indicative for the situation there. So one expert gave us this quote: "You need a strong head of the authority. Personally, I believe that a specialist in public health can handle this job very well, but only if they engage with the administrative system, meaning that they learn how to master the full range of administrative instruments." And unfortunately, and this is simply part of the truth, many of my medical colleagues do not outright refuse these administrative tools, but they avoid them. Yeah. So what we can see here, not only from the expert interviews, but this is also mirrored in the online survey, where we just asked for their formal qualification. We see that this field is still strongly dominated by medical doctors. Sorry, this was too fast. By the medical profession. We see that there's a little bit diversification in terms of qualification. We see that these doctors or these medicines, they do have additional qualification, either in public administration or business administration, a little bit public health thinking, but this is actually rather modest. Yeah. And also from the expert interviews, but also from the results of the online survey, we see that they are not really used to strategic thinking. Yeah, they have managed to go through the crisis, but now the crisis is end, and now it's daily business as usual. Yeah, so but no longer thinking how I can prepare my organization for the next crisis. So we have looked from a more qualitative perspective into their staff development concepts, into their education and training concepts. So a considerable share of the authorities, they do have these concepts. Here you can see it on the graph or the figure and below and on the under part of the slide. Approximately half of the authorities do have such concepts. Yeah, but they're just descriptive. Yeah, there's no idea of future in the concept. So they just tell me we do have a number of staff and they have this qualification. I do every year an update, but it's not specified on what. And it's also no idea how to bring the organization forward. I move forward to the next finding, and this is about resource capacities. And here we have really a picture of change. Yeah, remember these 400 billion euros, which was just thrown out over the system in 1 year. And what has happened? So we really see a short-term boost. Yeah, there's a huge influx of staff and funds. if you look at the figures on the second bullet point here, 80% staff increase. There's have new roles developed. We have now quite a number of experts related to digitalization. No longer medical staff, and also no pedagogical staff, just technicians. And this creates changes in the culture of this authority. But in the same time, there's also a long-term risk, and this comes to the fore also in the quote I have here brought with me. So far, I read again, so far we have had 2 funding programs. But of course, the major question is, what happens after that? So the funds, they need to be invested within 5 years, and we are now right at the end of these funding programs. So the major question is, what happens after that? We will still have the means to continue supporting our reforms, or will a good model simply come to an end because we don't longer have a way to sustain it? We need to ensure that funds are also a way of thinking about some form from a long-term perspective, continuation. That's always a problem with project-based funding. Sustainability often fails to follow. And we do not have the full picture because the funds are still running, but again, it's quite unsecure if the authorities can maintain this huge influx of staff. And an increase in staffing levels for 80% is really massive. And if you lose this again, you can imagine what this means for the resilience of an organization. Okay, let me move forward to the final slide regarding the findings. So this is capacities for the strategic organizational development. And again, this is our observation how the public health authority is set in the network of other authorities and civil society organizations. Is there a network, a supportive network, increasing, developed, and developing? We see very clearly that in some regions of our country and some local communities, these networks evolve, but it really depends on actors and their engagement and their personal motivation. It's not a structural reform. It's not a thing which remains or is stable, even if a leader changed the position. If the leader changed the positions, the network will break down. It's all based on actors' motivation and actors' skills. So really depends on the head of the department, so the leader of the public health authority. But in the same time, you need also to have the support of the mayor or the local parties in the local government setting. You need backing from the political sphere. If that's there, the recognition within the local administration is actually rather good, But you need a politician who has at least some affinity for health-related topics. And this is rare in our local community setting, because I can explain later, perhaps a little bit more in the discussion. Our health administration is totally separated from the local level. If you think about hospitals and ambulant care, it's a different, it's not connected to local health. And if you are in a board of a committee on a local government, it's you usually have a huge knowledge about street building and youth policies and school, but less about health. So even though, but I need to stress that there are 62% of the respondents have answered that they collaborative regularly with cross-sectional units within the municipality. But again, this is not, if we look at their open answers, what have they answered, what they really do there. It's more about exchanging data, exchanging everyday forms, but not about a more strategic thinking of how can I organize this network in a local level. So let's conclude. So what can we see? And I try to bring you back to our resilience framework and think again of the idea that there might be different types of resilience depending on the intensity or the degree of change. And we see here that the different dimensions of an organization or the different elements of an organization, that they move with a different pace or with a different intensity. Yeah, in terms of leadership, actually, we do not see much change. Yeah, laws have not changed what is expected from a leader there. We still have the medical profession, which dominates these positions. And again, we don't say that this is wrong, but for a modern public health authority, we would have expected that there are more expectations required from a leader. Yeah, additional training on the job, additional certificates, which also show their ability to manage, yeah, to organize network capacities, etc. So we say, well, in this dimension, we see only adaptive results, just bouncing back, yeah, going through the crisis without change. It's different when we go to the second dimension, the resource capacity, where we saw this huge influx of resources invested in digital infrastructure and invested in staff. Here we see what, obviously, after this long history of neglect and not investing in the system, we see a change. This could be a sign of absorptive resilience. But in the same time, we need to keep in mind that that there might be, and probably very sure is, a sustainability issue here, that this huge influx of resources won't be there for a long time, but might come to an end already end of this year after a 5-year period. This has implication for staff, but it is also implication for digitalization, which remains fragmented. And still, we see also from the answers of our questionnaire that staff is still lacking the skills to really use the modern infrastructure, yeah, and introduce it and make use of it for the everyday tasks. And finally, regarding the strategic development, the outside development of these authorities, we see here a modest adaptive shift. So depending on the motivation and the stamina and the energy of local leaders, both the mayor of the local communities, but also the leaders of the health authorities, if energy motivation is there in terms of actor capabilities, then we see strategic development. But this accounts only for a minor part of the overall setting of the overall sample. So a mixed picture. Strategic organizational development remains limited with no long-term systemic transformation. So with this slide, I suggest we come to a first end, and I'm very happy to answer any question which might come up now in our discussion. Thanks for listening.
Thank you, Professor Tanja Klenk. I think that we have a very interesting presentation. It's not a thing that it's really common in Brazil to discuss this kind of approach, looking at the how the system of a system of public administrations react to
Yeah.
new policies, the influx of resources, or even cutting resources. We had similar experiences here, of course, in Brazil because of our because of the pandemic, and also because we have a huge national health system. It's a public system. It's free for all, and it also during the pandemic it incorporated some traits of this approach about public health care and things like that. So it's quite interesting. I think it's a quite interesting and well a different way to look about
Yeah.
policies,
Yeah.
public policy, public administration, for us at least, I think. But I will open the floor to anyone that have questions. Anyone that have questions could raise the hand or make or make a comment in the chat.
There's one
Okay,
question by Luisa.
Luisa Arantes.
Yeah.
Yes, just a minute, Luisa. I will ask you, Luisa, can you speak now? Or if anyone want to write the questions, you can use the chat here. Yes, maybe Luisa, you can write here. You can write in the Q&A.
Okay.
Yeah.
Let me see. There is something. Okay. Yeah. Please go ahead.
Luisa, you can use the chat for the question.
In the meantime, I'm also happy to answer other questions. So with Luisa, yeah, there was one question, but the hand is again down. So there's no wrong question. Actually, you could also ask very basic questions about public health in Germany or health in Germany or also resilience as a concept, whatever, or compare it to your situation. So I'm also very happy to learn something about Brazil. So you can also take some questions as a stimulation if it's difficult to bring the paper. I always understand. So there's a lot of terms and empirical data, then you need to come up with a question. You can also start about thinking if this notion of resilience is something.
Okay,
Ah,
Luisa made her question, please.
okay.
First of all, thank you, Professor, for the presentation. I am interested in the last conclusion regarding the political support, also thinking about the classical work of Ellen Immergut and her findings on political institutions. How can you think we can use the insights you presented to think how political institutions can help to create resilience in health systems?
Yeah. So as I said, I think we need to think of a system of political institutions. And Ellen Immergut, so it's interesting because she thinks more about veto players and interests of one specific institution compared to other institutions, which is really interesting, but I see it more as an actor-centered perspective, which is slightly different to the thinking of resilience as complex systems. Yeah. So the complex system thinking is more about the interlinkages, the relationship between the elements of a system, but not necessarily about the interests and the strategies of one element within the system. Do you see theirs? However, if we if we leave the system thinkings and move more towards Ellen Immergut and her understanding of institutions, we can also study public health and perhaps see more or helps us more to understand why this part of the health system has been neglected for so long time. Yeah. And why we were not really prepared for COVID and had difficulties as other countries as well. And then it would be the answers that we give the doctors, which are actually, I need to say some words about the health system in Germany because it's probably different organized to what you have in Brazil. Yeah, doctors are self-employed in Germany in the ambulant sectors. They are entrepreneurs, yeah, and they administer themselves. Yeah, they're not integrated into the public system, but they have a whole independent system. Yeah. And the same is true for hospitals, yeah, which we call also self-governed. It's not part of our public administration system. Yeah, it's a medical profession-driven, self-governed administration. And the self-employed ambulant doctors, but also the hospitals, there is a huge status difference, yeah, and in terms of income organization, they are much more affluent compared to the public employed doctors in the local community level, yeah. And so coming from Ellen Immergut, we could say, well, there was a strong veto player in the ambulant sector and the hospital sector, which have overrides or overruled the public health system, yeah, and to this adds that the local system is also really weak in Germany with a strong federal and central level, but the local level is not really, it's not really involved in lawmaking and presenting its interests in the public sphere. And all these arguments explain the initial situation of having a rather weak system, which seeks now for resilience. I hope, Louise, that this was sort of a first answer to your questions. Otherwise, you can give me a follow-up questions and or others, and I can try to answer. Yeah, there's
Yeah.
Oh, okay.
Okay.
Mhm.
Is there any other question? I think that which is this difference between, well, your system may be more reorganized by the new public management. That's why you have this self-employed people
Yeah.
working with the public sector and things like that. Here in Brazil, what we really have is some social organizations taking care of entire hospitals and things like that. And what you are telling us is that this kind of arrangement creates a lot of tensions in
Yeah.
terms that it creates a divergent interest inside the public sector, isn't it?
Yeah. It
Yeah,
is. Yeah. It
that's
is. It's a and it brings pros and cons, yeah, or positive elements and negative elements. So so coming from the idea of being an entrepreneur, so the doctors are motivated, yeah, and then they really sort of take care of their patients, yeah, and seek to satisfy them. So this could be a positive stance in terms of consumer orientation. Yeah, you have this classical entrepreneurial spirit and taking seriously the customer needs. Yeah, explicitly it's say customer because it's this type of relationship. On the one hand, yeah, in the other hand, they provide a public service, yeah, healthcare, and are remunerated by public funds. Yeah, it's not tax-based. We have a different contribution-based system, which is separated from the general budget of our government. But nonetheless, it's a sort of public fund, and people are forced or expected, obliged to pay into the system. And you see immediately, so if you are customer oriented and want to satisfy the customer, you probably give them sometimes more what probably would not have been necessary in terms of just healing people, no, or increasing their health situation. And we are a comparatively rich country, but nonetheless, yeah, so our system is highly expensive. So it's as expensive as the US system, and the quality is not that satisfying. Yeah, if you look at mortality rates and also the classical measures, so how long do you need to recover from certain operations and measures? So the quality indicators are really poor if you compare them to the amount of money we invest or spend for the system. Yeah, and you see immediately the trade-off of having these entrepreneurs in the system, yeah, and not having really a public. It's highly regulated, but not in terms of spending. Yeah, so and we are working on that. This creates tensions because we invest also a lot in some parts of the health system, but for instance, not in the public health system, yeah, except for this crisis situation, even though we all feel that having a healthy city would actually help everybody, yeah.
Yeah.
And this is one of the debates we have here and how we can solve it. But first we have to get rid of the veto players of the medical profession or their say in the political system if we want to change the situation.
Yeah, we have always it is the professionals that are the vetoes, veto players, isn't it? We have the same situation here, for example, in higher education, where the real academic system are plays a real veto player role in shaping the public education in Brazil.
Yeah.
Okay, is there any other questions? Well, then, Professor Tanja, thank you very much for your availability, for your to being available to make this presentation so late at night here.
No, that's okay.
Thank you.
Yes, thank you again for giving me.
I am sure that it is quite interesting for all the students. It will raise some questions ahead in our discussions here. Thank you. Thank you to all.
Thank you, and enjoy the day, and was very happy to have the opportunity to present here our results. Thanks.
Okay, thank you.
Bye.
Bye.
I need to check where I go out.
Yeah, there is a door. Bye-bye.